front for strengthening public health capacity and outbreak response in Sudan. Through this webinar series, we aim to share experiences, promote learning, and build a stronger community of the FETP and public health professionals. My name is Dr. Samar Aoud Al Karim. I am a proud graduate of Sudan FETP. It's a pleasure and honor to be your moderator for today's webinar. So, about the topic today, our topic will be about cholera risk mapping for strategic control. This is both timely and critical as we continue to face recurrent outbreaks. Understanding how to move from reactive response to proactive preparedness can truly transform our public health systems. First of all, before we begin, there is a few quick notes. Please keep your mics muted during the presentation. You may post your questions and comments at the chat box at any time. We will have a question and answer session at the end of this webinar. Thank you all for your cooperation in keeping the session smooth and engaging. To start off, I am honored to invite Dr. Mohammed Najib, one of the distinguished leaders and mentors of Sudan FETP. He is the technical advisor. So he played a key role in guiding and supporting this webinar series from its beginning. So Dr. Najib, the floor is yours.
Thank you very much, Samar, for this introduction. And I will take this opportunity just to remind ourselves about the purpose of this webinar series. These webinar series are considered as knowledge exchange hub, aims to connect FETP alumni and public health professionals in Sudan as a platform for learning, collaboration, and continuous professional growth. It supports national public health priorities by promoting knowledge sharing, innovation, and the One Health approach across sectors. We have so many objectives actually. Among them is strengthening the network among FETP alumni and partners, and to be in touch and to be connected. This is very important because we have to continue as a one family forever. It is not only during the study period of the program, but it has to continue after graduation as an alumni for almost for an infinite. This is very important. The matter of connection and being together all the way. And it's important to encourage peer-to-peer mentorship and leadership development. We all learn from each other, whether mentors or graduates or alumni. This is very important. We have to continue discussing things together, irrespective of being a mentor or an alumni or even a resident. And it's important to support evidence-informed epidemic preparedness and response activities. This is also a very important part of our objectives and of our purpose on these webinars, is to enrich the evidence-informed decisions and activities regarding epidemic preparedness and response activities. And we have to show ourselves. It is not enough to join the activities. I know everyone working at his office or at his department is having a share in this epidemic preparedness and response, but it's very important to show what we are doing as FETPs. We have this webinar series actually as another objective is to to increase or to maintain the visibility of the program. As you know, the program has been frozen for the last 2 years without no new batches. Although this is the time where we really need, or the health system needs, field epidemiologists, but unfortunately, we failed to prevail technical financial support to progress with the program during these war years, these 3 years. We hope next year, 2026, will be a new start with a lot of activities being done from Dr. Montasir and from other partners to support the continuity of the program. Meanwhile, we have to maintain the visibility of the program and to prove ourselves that we are here. This is very important. For this reason, we are having this congestion of webinars. We would like to raise our voice and to make everyone feel FETP there, even it has been frozen, but still it is there, and we will keep hammering until the oil comes out, inshallah. طيب,
Thank you, Dr. Najib.
I'm very pleased with the topics. العظيم الانترنت حاجه وطالع خلاص.
Your network is
سامعينك كده
having some troubles.
الانترنت عندي مشكله فيها كبيره خلاص.
مشكلة عامة.
طيب anyway أنا I just would like to mention the titles or the topics which we already covered during the last few webinars was very promising. Am I still online or?
Yes, you are online. We can hear you.
يعني I just wanted to mention that we were lucky to have good topics to start with.
I think we lost him. Dr. Najib? It's okay, we will continue. And when the connection is okay with him, he will come back to us. So thank you, Dr. Najib, for this insightful opening. Now, it's a pleasure to introduce our main speaker, Dr. Ahmed Izzuddin, community physician and field epidemiologist. He is a graduate of Sudan FETP. Dr. Ahmed Izzuddin will share global methodological updates and Sudan's experience in cholera risk mapping for strategic control. Welcome, Dr. Ahmed Izzuddin.
Assalamu alaikum. You hear me well, Samar?
Yes, we can hear you. You can go ahead.
Thank you very much, Samar. And thanks, Dr. Najib, for opening this session today. And actually, I'm not a man of speeches, but it's actually of a great pleasure and honor and privilege to be part of this very important webinars series. And I actually always be very pleased and very proud to be part of anything related to the field epidemiology training program, the Sudan program, because I consider myself a loyal son, and I'm a graduate of FETP cohort 3, the last cohort before the funding cuts and the program to stop. And we hopefully, inshallah, it will start its activities in terms of training of the future cohorts to support the public health system generally in Sudan, and especially the part of the public health emergency management, to have a very strong system, and the system that focusing more on the preparedness part and the strategic direction in terms of dealing with the public health threats in the country. Uh, Thank you very much for introducing me. I'm Dr. Ahmed Izzeddin, as Samar mentioned. I'm a community physician, a field epidemiologist, working in the General Directorate of Health Emergencies and Epidemics Control at the Surveillance and Information Directorate at Federal Ministry of Health. And I'm very happy to be the main speaker in this session, introducing a very important topic that covers a very important aspect in controlling cholera, which is, as most of you know, that it is one of the major public health events in Sudan that we are currently dealing with, and day by day and on daily basis. So thank you very much. Shall we jump directly to the presentation, or there are some other remarks from other speakers?
No, you can proceed for the presentation. Do you need to for me to share the screen, or
No,
you will
I'm
share
going
it?
to share from my side.
Okay, go ahead.
Yes. Okay, just for me, if the screen is appearing from your end. Is it clear from your end, Summer? Summer, when
Yes,
I'm presenting, I can't see the reactions or the chat box.
Yes,
You
Ahmed.
can
Yes,
just
Ahmed. Your presentation is visible
okay.
and your voice is clear.
Okay, Dr.
thank
Nabil,
you, Dr.
welcome
Najib,
back.
for that. So, our session today, as Summer mentioned, it's about cholera risk mapping for strategic control. We're going to give some highlights on the global methodological updates for that, and some about the Sudan experience applying and implementing these new methodologies. So the contents of our presentation will be, we will have some background on cholera itself. We'll move to the control pillars and the control approaches. We will give some definitions on the risk mapping and prioritization. And of course, the most important part, which is the updated methodology of identification of cholera priority areas for intervention, and some on Sudan experiences, and the next steps after identification of these priority areas. What are the next steps? And I will take you in a very short tour in the Global Task Force website, and the very huge materials that you can use, and you can go through to have more detailed information on cholera and its control and the global directions. And the last part would be on the questions and responding to all your points. But just to highlight here, this will not be the only part where we can respond to your thoughts or your reflections or any points to be raised. So you are encouraged to to not only use the unmute yourself and raise any points, but also using the chat box to add any thoughts, points for clarifications, insights, and so on. So we need it to be a more of an interactive session and more engaging session rather than a one-man show lecture. Okay, so the first slide is about the background. So, as you all know, that the cholera is an acute severe illness caused by infection with Vibrio cholerae, as different serotypes and different serogroups, and actually, it's one of the major public health risks that the globe is at the level of the globe is dealing with, and even regionally and nationally, of course. If you know, the cholera is for Sudan, it's the #1 priority notifiable disease in the priority notifiable disease list. If you are familiar with that list, it's the first disease, notifiable disease, and not only on the documents or on the papers. It's the first one. Even on the ground, it's one of the major risks that we are dealing with, as I mentioned, day by day. However, now as we can see, the trends of cholera are declining in our country, and as we have been experiencing the most huge outbreak of cholera following the eruption of conflict to its 2 waves. But now, fortunately, the trends are going down, but we're still dealing with cholera day by day, and it's one of the major public health events, if you can say, public health events of national concern that are dealt with on daily basis. So the actual global burden of cholera is largely unknown. The only numbers that you can find here and there are only 5 to 10% of the real global burden. This is according to the WHO, and actually this is due to the underreporting, as stated by the WHO, and this underreporting is always the challenge due to several factors, some of which is the limited epidemiological service and laboratory, and there are other factors that are related to economical aspects, social aspects, and even the political aspects, as cholera might not be declared or might not be encouraged to be reported due to some political aspects in some regions or some countries. And actually, the cholera is strongly linked to humanitarian crisis, as humanitarian crisis, and particularly the conflict settings and context, brings some conditions that are favorable of cholera spread, like the displacement, the massive displacement, and the overcrowded displacement conditions in camps, and the direct effect of conflict on the health system in terms of health system collapse and disruption, and even the impact of conflict of infrastructure, and particularly the wash infrastructure, and many other conditions that facilitate the resurgence or the widespread of cholera during these contexts. The global roadmap, the global cholera, the global task force for cholera control, has the world global map of ending cholera, by not ending exactly, but reduction of the mortality due to cholera and elimination of cholera in a number of countries, out of all the countries that are reporting cholera globally. And this goal is actually very ambitious, as it is said that the main 2 goals is, the first one is reduction of cholera, a reduction of mortality of cholera by 90%, and elimination of cholera in 20 countries out of more than 40 countries where cholera has a high burden. And the global task force put 6 control perils to control cholera, and these are implemented as a multi-sectoral task, not one entity task. And these 6 pillars, as you can see here, the most important of which is leadership and coordination. This is the pillar that brings all the actors and the relevant partners together to have one plan, one roadmap, and to pool all the resources, which is, of course, limited, especially in context where cholera is spreading. The case is always fragility. So this is a very important pillar, the leadership and coordination. We have also water and sanitation. We have surveillance. We have also the OCV, which is the new control pillar, and now the international coordinating group in vaccine provision is providing oral cholera vaccine as part of cholera response, as reactive response strategy for cholera with the oral cholera vaccine. We have also the healthcare system strengthening as the last pillar. There are different schools classifying these pillars. You might find some schools talking about 10 cholera control pillars. Other might talk about even more than 10. Other might talk about 7 and 8. But they are all agreed upon one theme that where all the required cholera interventions are addressed within these pillars, regardless of their numbers. For example, here in the health system is strengthening. You can find the case management pillar inside this pillar. You can find the infection prevention and control. You can find the supply also, and many other related cholera control interventions. So what some of you might ask why this treasury box is here in this slide, because actually I bring it because always whenever we deal with the cholera issue, we have a very important challenge, which is the scarcity of resources, the limitation of the resources. So we have to be very smart and very efficient on using these very limited resources in controlling cholera in the way that we have the best impact and reducing its morbidity and mortality. We don't have enough money and enough resources to fill all the gap and to implement all the interventions. But we have to pick from this intervention what is the most priority and where is the most where the most priority area we can intervene, and we can have the best impact in terms of the control, and we can even reduce the spread from this area to other areas. And when controlling cholera in this area, we also indirectly control it in the other area, because this is a major area of spread and recurrence of cholera. So this treasury box you might see in the next slide also, and it's very clear that we don't have the resources, only one golden coin. So what we can do with this one golden coin, it's a golden one, so it can do something. Of course, especially during these days, we see some increase in the price of gold. So the old slide, the former slide was on the pillars of control. So here we are talking about the approach of control. When we are controlling cholera, we might take either of which. If we are doing that with a reactive approach or the proactive control approach. So, and this reactive one is after the occurrence of the outbreak, we react to that and we respond if there is any outbreak occurs. And this actually, some experts describe it as the firefighting firefighting approach. You just wait for the fire to 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 spark, and then you react to fight this fire and to put it down. Short-term gains. However, we still have the long-term vulnerability. And if you are a fighter and you are not prepared for this fight, you are unlikely to win the battle or to win the fight. Even if you win some rounds, you become fatigued and you become overwhelmed, and you are most probably lose the other rounds of this fight. So this approach actually, now we are going to compare between these two approaches in the coming slide. There is a clear table comparing many aspects of these two approaches. So I'm going to move to the other one, the proactive control. So this proactive control ensures sustainability, and you are prioritizing here, and you have some structural analysis, and this inform you where to intervene and where to allocate your resources and who to mobilize and who should be involved and how to involve them and so on. And here you have a lasting impact, and and this is actually the best approach to control cholera, and it is based on the risk mapping. The risk mapping is the foundation for shifting from reactive to proactive. So the first step, you are prioritizing. You have a clear priorities, so you can continue with this proactive approach, leaving behind your the reactive approach. Okay, so these are the comparison between the two approaches in different aspects. Here, the nature of response. In the reactive, you respond after the outbreak occur, as we mentioned. And in the proactive, we prevent outbreaks before they occur. The timing also, here the short-term actions, and here is planned continuous interventions, and some aspect is the cost. Actually, the cost is high in the reactive approach. And here, when we talk about the cost, we're not only talking about the money or resources. We are talking about lives. Actually, when the outbreak occurs, there is a high chance it might go out of your control, and you might lose a significant number of lives. And this is actually one of the costs of the outbreaks. But if you are well prepared, you are more likely to prevent the outbreak occurrence. And even if it occurs, you are in a best place or in a better place to contain it very efficiently, and you have less, and you not even in a less, you can even prevent that significant number of death you can see in other in the other approach, and so on. These are the many aspects, and if we look at the outcome here, outcome aspect, in the reactive one, we will have repeated outbreaks, and we'll have resilience. But in the proactive approach, we have a resilient system, and we have a lasting impact. And the key analogy here is fighting a fire without preparation, and here we are building a fire-resistant system. So why prioritization? This slide is about why prioritization and structural analysis. In a non-direct way, we already answered this, but I would like you to put in the chat box some possible answer for this question. Why we prioritize? Why we do structural analysis and in our quest to control cholera? Put your response in the chat box, and we're going to see the common themes between you. I think the treasury box, you see it again, and it gives some hints of what could be the answers of this question. So I don't see the chat box, but I think now I give you I gave you enough time to put something in the chat, thoughts or any reflections regarding answering this question. So we need to prioritize because of the fragility. And I said before, as I said before, fragility is linked to the scarcity of resources. So I have this very limited amount of resources, and I have this gap in front of me. So I can't put all what I have arbitrarily. So I need to know exactly where I should put this very small amount of money to get the best impact. So these are the key terms. I hope you put some about it in the chat. We have fragility, limited resources. The gap, of course, is very huge. And when we are analyzing, we are thinking about the impact, what impact we are aiming to. And why prioritization and why structural analysis? I think we can summarize the answer is to know exactly where to intervene and where to put these very limited resources for the best impact in controlling cholera. So what is risk mapping? I think some of you might be familiar with this risk matrix, but yes, in risk mapping, we are assigning risk to specific geographical areas, and actually they're different but similar. Anyone knows what are the differences between risk mapping and risk matrix? So in risk matrix, actually you are using the mathematical formulas to assign the level of the risk. The level of the risk, whether it's very high, it's high, moderate, low risk, and some literature also talking about no risk as part of the no risk, low risk, moderate, and high and very high. And you give a specific color according to the level of risk. This is a risk matrix. It's based on mathematical analysis of some specific measurements. And the risk mapping is the geographical display of this risk levels according to the geographical units. So some units categorized as high risk. And here you have a map. In this map, you are displaying the risk based on the prioritization exercise you have done. So the definition of risk mapping and prioritization. Cholera risk mapping is the systematic identification of geographical units, potential hotspots, where cholera is recurrent or persistent in order to guide targeted interventions. And actually, this is according to the WHO and the Global Task Force up to 2020. But now the theme and the idea is a little different from what we have already known before that, because now they are talking about the identification of priority areas of multi-sectoral interventions. Formerly, the term is hotspots, cholera hotspot areas. This is based on on specific indicators, and now they are no longer hotspots. They are BAMIs, which is priority. It stands for priority areas for multi-sectoral interventions. And BAMI's identification process, which is the former risk mapping or hotspot mapping process, now it refers to the process of identifying a subset of operational geographic units that are most at risk of cholera transmission and that will be targeted for multi-sectoral interventions. Why these subset of geographical units with cholera risk? Because this subset, you can't invest or allocate your resources for all the geographical units that experience cholera, whether they are and first you need to prioritize, and it is the same concept as investing in the priority areas for the best impact. And these priority areas are areas with the highest cholera risk, and here we are talking about the highest morbidity, the highest mortality, and the recurrence of the risk. The risk is always starting from there. They are always the source of spread of cholera. And when you invest on them, you are more likely to control cholera uh, even in the other areas that are not part of this subset. So now we're talking about the BAMIs, which are the priority areas for multi-sector intervention. Formerly, we were talking about cholera hotspots. And BAMIs identification methodology, according to the most updated Global Task Force, GTFCC methodology, how to identify BAMIs. Actually, we have two methodology according to the objective of the country. If we are aiming to control cholera, we use a specific methodology. If we are aiming to eliminate cholera, we are talking about other methodology. So in Sudan, we are our aim is to control cholera, because cholera is still high risk, and we have high burden of cholera. We don't have very low burden, so we can target the elimination. We still have a significant burden of cholera, morbidity, mortality, and very significant number of geographical units that are experiencing cholera, or where the cholera risk is still one of the public health risks the health authorities are dealing with. And this methodology actually released in 2023, and it's supersede all the previous methodologies. So if you want to align with the most updated methodology, you need to use this. And if you want recognition from the Global Task Force, you have to do your prioritization based on this updated methodology. So you have it recognized and endorsed by the Global Task Force, and you can get use of the opportunities that are following the process of identification after your BAMIs are endorsed. So you have to do this to access two very important benefits. If you have endorsed subset of BAMIs by the Global Task Force, you can access the so-called preventive OCV, which is different from the reactive one that we use in response to cholera outbreaks. Here we use the OCV as a preventive measure. And here they use different strategy, which is 2 doses. And these 2 doses have protection of 3 years. And these 3 years will be the time for you to strengthen your other pillars, like the WASH infrastructure, like the health system, like the community engagement and health promotion, and so on. So you will get access to this when you do this prioritization task. And another one for a country, national cholera plan to be endorsed by the Global Task Force. You have to base your the national cholera plan on this prioritization exercise. And if your plan is based on this exercise, it can be endorsed by the Global Task Force, and it will help you to mobilize partners and to gain the recognition of partners with your plan, and so they can mobilize their resources, or they can contribute to your efforts in controlling cholera. So and these are also other benefits of the methodology, the new methodology. You will have a data-driven decisions when you use this methodology, and it's very flexible because it takes into account the contextual factors, and it also promotes consensus, as it is done through validation from all the stakeholders that are involved in cholera control. So it promotes consensus, and it fosters stakeholder engagement, very clear, and come with supporting materials. You will get the support of the global task force itself, and they will provide you with all the required materials, and so you can do this task successfully and in the right way. And also assistance, as I mentioned, by the global task force, and also the international recognition of this prioritization exercise and the list that will come out of this exercise. These are very important, so you can benefit from the prioritization of cholera intervention areas. In this slide, values for cholera, as I mentioned, we have data-driven phase. This is where we review the data. We identify the period we are going to target to analyze our situation, and this data-driven phase will end up with assigning specific prioritization index to each cholera-affected geographical unit in your country, and then you move to the decision-making phase, which involves the validation of this list and these priority areas, and then you reach a decision on what the priority index threshold to be used, and then according to that priority index threshold, you select or you include the priority, the geographical units in your final list, and this list will be validated by all those stakeholders, and then you send that to the global task force for endorsement. So what are the indicators that are used for this prioritization of priority areas of families? We have 3 epidemiological indicators and 1 testing indicators. They are not putting the testing with the epidemiological indicators because these are always part of the process. The 3 indicators are always part of the process, but the testing is not always part, because in most of the countries it is insufficient. We are going to talk about this in more detailed way, why it could be sometimes insufficient, and it could be sufficient, and it could be suboptimal, and so on. So you need to remove it from your prioritization, so the process is not biased by any factor that could bring bias. So we have the incidence, we have the persistence, and we have the mortality, and we have the testing representativeness. These are all the indicators that we use. And we have another indicator, which is vulnerability. We are going to talk about it, but these are all indicators that are measurable. You can measure them, and you can have some scores for them. So the incidence is the number of cholera cases suspected and tested in the analysis period. The persistence is the proportion of weeks with at least 1 cholera case reported in the cholera case, whether suspected or tested or confirmed cholera. The proportion of weeks with at least 1 cholera reported, 1 cholera case reported in the entire analysis period, and the mortality is the number of deaths in the analysis period. So how we assign a score for each of these indicators? We use the median and the 80th percentile, and according to the median, we assign a score. If in a very quick way, I don't want to go into details of the details of assigning the score. You can find that in the website of the Global Task Force in a very, very detailed way. Even the tool it can be downloaded from there. So you assign the median, and if the incidence, for example, if you take the incidence as an example, if the incidence between the 0 and the median between 0 and the median, you give a score of 1. If it is above the median but below the 80th percentile, you give the score of 2. And if it is above the 80th percentile, you give the score of 3. For each state, here or for each geographical unit. This geographical unit could be the state, could be the locality, could be the administrative unit, could be even the neighborhood. This is according to the country interest, whether they want to go down in the analysis level to the locality or to the administrative unit level. But what is always recommended is to go down to the admin level 2 and 3, which is the locality or the administrative unit. So each unit, each geographical unit will get a score according to this median and percentile in each indicator: incidence, persistence, mortality, and even the testing representativeness. So these, for example, are the points. If it is 0, it gets 0 point. If it is more than 0 but less than the median, you get 1 point. If it is more than the median, and so on, as I mentioned in the previous slide. This is for the testing, scoring for the testing positivity indicator. It have a different way of testing. But we need first to know what this means, testing positivity or testing representativeness. I think I included it in one of the slides. Oh, no. So this testing representativeness actually is based on the number of GU units that have at least one cholera case tested in at least 50% of the weeks of the analysis period. So it includes two criteria. The first one is two criteria. The first one is at least one cholera tested, at least 50% of the weeks. If you have this less than 50%, you assign the testing positivity as something different. If you have the geographical units with at least one cholera case tested in at least 50% of the weeks, less than 80%, your testing here is assigned as insufficient. So you can include this indicator within your scoring system because it provides a biased scoring and a biased results. Actually, I know this might be some extent a complex process, but you can find it in more details in the materials that I'm going to recommend to you by the end of this session. So how we calculate the priority index? Actually, the priority index is the sum of the scores of all indicators. So for example, if the geographical unit is Kasala locality, for example, this Kasala locality, you score it by the sum of the scores for each indicator. So if the locality got 3, for example, got 3 in the incidence and 2 in the persistence and 2 in the mortality and 1 in testing positivity, the sum of the score for the locality, I think it's clear now. The sum of all the scores will give you the priority score. And then according to the priority scores, we are going to identify our boundaries, as I'm going to mention in the coming slides. Sometimes, reliability of the priority index. In some units, geographical units, the priority index may underestimate the cholera burden. In some units, if we rely only on the indicators, we might not include some of the localities that may be highly vulnerable according to the contextual knowledge, might not be included. And this is why the epidemiological indicators and testing themselves are only cannot be the best way to to categorize all the localities. This is why the global task force added a new indicator, which is the vulnerability factors. So you don't base all your analysis on the indicators only, but you have the so-called the vulnerability indicators, and these are actually the contextual factors, and these are well known by the the the, the field experts, or the staff maybe, or the actors in the field in that specific geographical unit. You need to have their insights. You need to collect about the vulnerabilities and the factors like this, so you can classify this locality as part of your priority areas. Because if you depend only on the other indicators, such localities might be excluded and not be part of the priority localities. This is why we include the vulnerability factors, and why the global task force added this to the analysis process. In the former hotspot mapping, by the way, we only have two factors: the incidence and the mortality. All the other factors were not part of the analysis process when we were talking about the former risk mapping, which is the hotspot mapping. So it's very clear now, the methodology, the updated methodology, is very inclusive of many factors, and is more of giving more accurate result compared with the former methodology. So after you assign a score priority index for each of your geographical units, then you bring this list and you put it on the table of the stakeholders, all the stakeholders who are involved in cholera control. So and then you need to agree on what the so-called priority index threshold. Of course, in your list, you have localities with 10, with the score 10, priority index 10. You have some with 9, some with 5, some with 2, 1. So what to be included? You need to have a subset of priority areas for multi-sector intervention. You can't include all the geographical units with where cholera is a risk. You need to include the priority areas, the priority localities. So what should be the priority index threshold beyond which all the localities are assigned or classified as priority localities, and the others are not priority localities? So the stakeholders, after intense discussion, they should agree on the priority index threshold. For Sudan, we have the priority index threshold when we have been through this exercise, the priority index threshold of 6, and all the localities scored 6 or more were included as priority areas for multi-sectoral interventions, and they were 52 localities. I'm going to talk about this later. So the stakeholders agreed on the priority index threshold of 6. So all the localities scored 5 and down were not part of the priority areas of multi-sectoral interventions. And this decision about the priority index threshold actually is a process that balance between the threshold set, the feasibility and the impact. The feasibility and the impact. If you put the priority index threshold as very low, like if we agreed on 3 as a priority, so of course the number of localities will be very high set of localities. And when the subset is very high, you are actually putting or your exercise will get some questions in terms of the feasibility. Are you able, will you be able to include all these cholera plan as priority areas. So the feasibility is very important. You have to balance between the feasibility and the impact. So what we mean by the impact? So the impact is the localities where we have high burden of cholera. We mean high cases and high deaths. And when we intervene, when we have this as one of the priority areas, actually, we will reduce the cholera morbidity. When we invest on this, when we implement on this locality, we will have a considerable reduction in morbidity and mortality. So we will have a very good impact in terms of cholera control. But when we increase our number of localities, then we are going to put some resources in some localities where we can where we will not be able to obtain a good impact in the overall reduction in cholera morbidity and mortality. So this is very important, and it's a principal part of the discussion, of the stakeholder discussion, to take the decision on what priority index threshold to be agreed upon. I hope this is clear. So this is the same as proxy of feasibility and impact, as I mentioned, the cases and deaths and GE units and population and so on. The Global Task Force, for example, recommend that the geographical units you select as the set of priority areas for multi-sectoral interventions to cover maximally 30% of the population, and more than 80% of the cholera deaths, and more than 80% of cholera cases. So actually, now it's very clear when the BAMIs, the list of BAMIs you select are covering this significant proportion of population, 30%, and it covers the more than 80% of the cases in the analysis period, and more than 80% of the deaths, you are more likely to get a very good impact if you intervene, or if you include this in your national cholera plan as priority areas, and you allocate resources to control cholera in this area. You are more likely to get the best impact. So the countries are also allowed to put some additional BAMIs. These additional BAMIs are also based on the vulnerability of cholera, and these are the localities that scored very low, but they still have, as I mentioned, they still have vulnerability factors that categorize them as very important areas that we should target and we should intervene in. So according to this, you are allowed to put some set, very small number of localities called as, or named as, additional BAMIs, and this is based also on the vulnerability and the feasibility of intervening in these areas. So this is all about the methodology, the updated methodology of identification of priority areas of multi-sectoral interventions, formerly known as cholera hotspot areas or localities. And now we reach the last slide on identifying these areas and the updated methodology according to the Global Task Force. In the next slide, we will talk about the experience of Sudan. Very short insights on what Sudan have done in terms of sectoral intervention. It's BAMIs. And actually, before the new methodology, Sudan have done this hotspot mapping exercise in 2020, late 2019 and 2020, using the Global Task Force methodology, the old methodology. And that, as I mentioned, that methodology uses only two indicators, which are the incidence and persistence. And that analysis, all the analysis covered the period from 2015 to 2019, and they identified 12 priority localities in 6 states using the epidemiological data of the 2 indicators. And this map is actually about the risk mapping of cholera at that time, covering the analysis period. You can see the deep red color is the localities with high risk and so on. Some of them, as I put here, high risk, like Abu Hajar, Sinja, Sinnar, Salam, and Agitena, and mostly in the White Nile state. So this is the former exercise. So this actually indicates that Sudan Ministry of Health always trying to use the available evidence-based methodologies to have a clear cholera risk mapping to inform their plans and their direction in controlling cholera. And actually, in using the new methodology, there was a committee that formulated in late 2024 using the most updated methodology, the GTFCC 2023 methodology for BAMIS identification, using the indicators we mentioned: incidence, persistent, mortality, testing representativeness, and vulnerability. And the analysis period covered was 2016 to 2024, up to December 2024. And this was actually a very important exercise that been done in a very fragile and very critical times to inform the strategic cholera control efforts, and to inform the country roadmap in controlling cholera. And this is actually some of the findings from the exercise. So based on the indicators, we identified sorry for that. So we identified 52 localities as priority areas of multi-sectoral intervention out of 152 localities. So in all the analysis period from 2016 to 2024, cholera has been reported in 152 localities. Of them, 52 localities were identified as BAMIs, as priority areas for multi-sectoral intervention. And actually, these BAMIs, regarding the number of cases, they reported, all the 52 localities reported more than 80% of the cholera cases throughout the analysis period, and more than 77% of the cholera death in the analysis period. So they are really the priority areas where we should prioritize our interventions, and we should prioritize in our national cholera plan. And this exercise was successful, and it actually endorsed by the Global Task Force. This list of BAMI and the identification report was endorsed by the Global Task Force in early August, last August, and now this list is being used, and even the outcome of this exercise is being used in terms of planning and in terms of guiding the interventions and so on. We have some brief slide on brief immediate strategic applications of this BAMI. So after the endorsement of the BAMI's list, this list is used as evidence by all actors, and I think Dr. Asia Dahab is attending this session today, and one of the leaders, Dr. Asia, one of the leaders during that exercise, because the WASH aspect, and the WASH pillar is one of the most important pillar in the analysis and in the cholera control, of course. So Dr. Asia is now using this list of VAMI in the WASH cluster planning and WASH cluster meetings and forums, and all the partners in these sectors or in these forums are using the endorsed list of BAMIs to base their planning and to inform their actions and to guide their interventions within the field, and as a very important evidence for better coordination and better collaboration regarding the cholera control in the WASH sector. So this is the first one. It provided evidence for all actors. And the second immediate application for strategic control is the preventive OCV request development. Sudan also finished now the development of preventive OCV request, because the preventive OCV is entirely relying on this identification exercise. If you don't have endorsed list of priority areas for multi-sector intervention, you cannot apply for the preventative OCV application. And now we already finished the development of the preventive OCV application, and the other strategic application, immediate application of VAMIs is the development of the strategic preparedness and response cholera plan up to 2030, from 2025 to 2030. And actually this is in its last steps, and it is it's being developed now by the dedicated team from the Health Emergency and Epidemics Control Directorate, and the supervision of Dr. Muntasir, and part of the process, part of the those who are leading the process, Dr. Sabir, who is also a commentator in this session, and other colleagues like Khalid al-Jamri and so on. And Dr. Muntasir is also with us here. So these are the immediate application of the newly developed list of, or endorsed list of priority areas for multi-sectoral intervention. So after identifying these priority localities, what could be the next steps? So to me, and actually this is not part of the session as part of the methodological updates, but it's a kind of recommendation. So because to me, I think the global task force methodology in identifying the priority areas for multi-sector intervention needs more lower level model to support its successful application or efficient application of the interventions even in these priority areas. So now, for example, Kasala locality, for example, Kasala locality is one of the priority localities. So we have to include in our planning and in the strategic interventions for cholera control. But how we can how we can navigate through this process of investing or allocating of our resources, location of our resources in this specific locality? I think this needs further deeper analysis and deeper structural analysis for more efficient use of the limited resources, as we mentioned before. So what we propose here is the adoption of the systems thinking model for root cause analysis. So we have cholera in Kasara locality, but what are the best way we can strategically intervene to strategically control the cholera in that specific? I think this needs deeper analysis using one of the models, that root cause analysis models, and these models are actually very interesting, and they are very important and informative for better outcomes in terms of public health event control generally, not even the cholera. For this system thinking model for long-lasting impact. So this system thinking, one of the models is the iceberg model, and this iceberg has 4 levels. We have this the tip of the iceberg. What we see in terms of cholera is only the symptoms of the problem. This is how we can interpret what is put in this slide. So the event, what you see, and the lower level, which is below the surface of the water, below the surface is the patterns, trends, what keeps happening repeatedly over time. You need to have some insights on this level, and when you go more deeper inside below the surface, down below the surface, you have the systemic structures, the underlying systems and relationships driving these patterns. Why these are happening? What in the system is it could be an underlying relationship or underlying cause for the occurrence of this. And the last level under the water is mental models, the beliefs, actually the norms, the systems. Here we are talking about the system itself. What is this, the norms in the system? What did the system believes that shape system behavior? And we have example for each of this. So the first one, the event above the surface. Above the surface, we see recurrent cholera outbreaks, increasing cases, and rising death. And for the patterns or the lower level below the surface, we have seasonal spikes during rainy season, for example. We have repeated outbreaks in specific areas. We have short-term commitment followed by relapse, or containment, sorry, followed by relapse. For the system structures, we also see weak health infrastructure, for example. This is why the problem keeps coming up, and it's always one of the problems that we have to deal with each year, for example. So this deeper analysis will provide very good evidence for more lasting interventions and impact. In the third level, we have also poor coordination. What is the status of our coordination? Is it a powerful, or is it a strong coordination, or it needs to be strengthened more, or it needs to be better, to be invested in, to be better? So the reactive funding, for example, the available funding is only for the reactive approach, for example. This also needs to have some focus. And the population displacement, maybe the poor urban planning, and many other aspects that are related to the system structure itself, that we need to analyze and to put some efforts to address these related aspects of the system. The mental models, maybe the system itself has the belief that cholera outbreaks are inevitable, or we are thinking systemically that limited short-term or donor-driven response mindset, the system itself. And when I talk about the system, it's not the Federal Ministry of Health, the whole system that is part of the cholera control. The system could be from the national level lower down to the health facility, and all the actors are involved as part of this system, even the humanitarian system, and the organizational system, and the governmental system, and so on. So all of them are part components of one system, which we are talking about now when we say the mindset, donor-driven response mindset, and limited culture of data-driven decision. What is our culture? Is it a data-driven decision-making culture, or we are still we need to have to change our culture and we need to invest on more evidence generation, more research, more analysis, so we have informed decision or data-driven decision-making process. The focus on crisis management rather than the prevention. What is the behavior of the system? Is it more to the prevention or more to the crisis management and response 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 behavior rather than the preventive or prevention behavior? So this is actually a proposed model for thinking deeper in the problem to have good outcomes in terms of responding to this problem or addressing this problem on the long term and have a lasting, very long lasting impact. So investing below the surface is very important. Investing below the surface. Without systematic problem analysis, we waste scarce resources. I always stress on this point. We waste scarce resources. It's always scarce. It could never be sufficient. And I don't think we, in the near future, we will reach a point where we can say our resources are sufficient and our resources are enough. They will still, they will be scarce, at least in the up to the very coming times in the future. So they are scarce and only reacting to the symptoms rather than preventing them. So to break this cycle, we must invest below the surface in systems, not just in response. And I need here to highlight the importance of the research. We need to invest in research, and we need to change or to shift to the culture of research, because it's very important, and the evidence generation is very important to have data-driven decision or evidence-based decisions, planning, interventions, and every activity that should be based on the evidence. And the last thing is the One Health. One Health is very important, and actually we talked about it indirectly when we talked about the multi-sectoral intervention, and this is very important aspect, the multi-sectoral aspect. So everyone should be involved, and One Health is now not only about the zoonotic diseases, no, but about every health problem and health challenge. We need to react together. We need to even think together, decide together, and plan together, and intervene together, the different sectors, all the sectors together. So we come to the end of actually our presentation, but this is a very short. I hope I'm sticking to the time allocated for me. So this is very quick tour in the global task force website. But this website, it's very rich with very huge amount of materials regarding cholera and its control and its the roadmap and even the global efforts, and regional and even national insight from some countries. So this is the global task force website, and here you can see the cholera strategy, the global roadmap for cholera control, and this is the strategy, and these are the main goals of the strategic goals, which is a reduction of the mortality, and these are the themes. And even you can see how they link this to the sustainable development goals, and particularly goal 3 and goal 6. Those are about the health and about the water and sanitation. And cholera is even related to other sustainable development goals, like the poverty, the equity, and the climate change also, and many other sustainable development goals. So this is the Global Task Force website. The important part, we have a window that is called resources. As you see here in the above headings, these resources. And in these resources, you have this course is a very important course and very intense and very rich course, which is identification of priority areas for multi-sectoral intervention. And you can have the materials in different types. You have the videos, you have the PowerPoint materials, you have the PDF materials, and you have them in different languages. If you are interested in English, you will find. If you love to read them in French, you will also find them. So these are the materials, and like they have 5 modules only for this topic. You see, this is a video. These are the materials. You can download them in PPT, PowerPoint presentation. You can download them as PDF. You can download them in different languages as well, and they are very, very huge. This is about the cholera control. You can find some about the case management. You can find some about the community engagement part. You can find some about identification of values for cholera elimination, not cholera control, and many other materials that are very important for those who are interested in cholera and the cholera control at the global level and even at the regional or national level. And actually, we come to the end of our presentation. Don't know, the laptop become very slowly responding to mine. So this is if it appears from your end, this is the last slide. Thank you very much, you all the attendees, from our colleagues, our supervisors, advisors, and our senior colleagues from the Ministry of Health uh, uh, and other institutions or organizations. Uh, uh, I hope it was a very useful presentation and very useful materials that I presented. For any further, you know, materials or any recommended courses, I'm here. I can recommend even further helpful and useful websites and courses for cholera for those who are interested. Thank you very much. This photo is when we were responding to cholera through oral cholera vaccine in Kasala locality, and with those very lovely children after they received the cholera vaccine. They were very shy taking this photo with me, but we finally managed to took it. And it's a good memory, actually, by the way. Thank you very much. Back to you, Summer, if you hear me.
Thank you, Dr. Ahmed Azzuddin. Excellent as usual. And this was a very comprehensive and insightful presentation. We truly appreciate your valuable contribution to us. You can take some time to look at the chat box because you have very interesting comments, and we will get back to you at the questions and answers session. Now, next, I'm delighted to introduce Dr. Saber Ali Mohammed, the community physician from Health Emergency and Epidemic Control Directorate, and he is the coordinator of Sudan FETP. He will provide his reflections and comments on the topic which Dr. Ahmed has raised. Welcome, Dr. Saber. The floor is yours.
طيب السلام عليكم ورحمة الله وبركاته. Thanks, Samar. Thanks, the organizers for this forum. Thanks, the unknown soldiers behind this good work. First of all, let me to greet our colleagues and to greet Dr. Montastir, the manager of the program, and the ex-manager of the program, Dr. Mohammed Al-Hafiz, Dr. Najib, the technical advisor, and the ex-technical advisor, Dr. Fatih Malik, and to our colleagues our partners from WHO, Internet, and our guests also. I think this is a very good and very successful forum. Before I comment to the presentation of Dr. Ahmed, first let me to highlight some on the speech of Dr. Mohammed Najib said in the beginning of this forum, and he mentioned that the program suffered more for 2 or 3 hours, and that they come cut from the program. And we are working with the limit, the minimum limit of work. We are maintaining visibility of the program, and we are keeping doing the minimum activities. And here I want to repeat the word Dr. Najib said, that we are keeping digging until the oil comes out. Secondly, I want to comment on Dr. Ahmed Zadin presentation. Thanks, Dr. Ahmed, very much for the rich presentation. And I think the topic covered very well. First, I want to say that we have cholera outbreak since August 2022, and still ongoing in the Sudan. So the topic, I think it is very useful and very important that we to deal seriously with the ongoing matter. I think the matter is aggravated by the ongoing war and the environmental exchanges that are happening in our country. Dr. Ahmed Zadin mentioned a lot of topics, and he mentioned the control or the pillars of the control for the cholera outbreak, and mentioned the 6 pillars. And he also said that the pillars may be varied from time to time, or sometimes being more than 6, sometimes 10, and also, and WHO also recommended that 10 pillars, and putting some pillars in some themes. Here we can go rapidly in these pillars in coordination, put in one theme. In surveillance, we are putting surveillance and laboratory in one theme. In the community protection, we put 3 pillars: risk communication, RCCE, and wash and vaccination. In safe and presentation care, we can put 3 pillars: case management and infection prevention control, and continuity of the service itself. And in the last theme, you can put countermeasures, research, and this is operational support like logistics and research. So this is the also famous 10 pillars for cholera control. Here we have some questions for Ahmed, Dr. Ahmed, and that we are realize sometimes some fragile and risky areas might be excluded from BAMIS if we only use the epidemiologic indicators. And here I think we have an example. In Muwaba locality, for example, there is still ongoing outbreak taking place there. And this locality is not from the BAMIS and excluded even from the OCV pillar for prevention. Also, the second question, what does the Global Task Force provide to to help the countries progress to achieve the road map. And the last question, what is beyond these control strategies that could be ensured for the best control outcomes? Thank you very much. Thank you, organizers, and the floor is yours, Dr. Samad. Thanks very much.
Thank you very much, Dr. Sabir. And Dr. Ahmed Izzeddin is facing some technical difficulties with his laptop. So, meanwhile, we will open the floor for the questions and answers. You can feel free to raise your hand, and also you can comment your questions at the chat box. So first of all, Dr. Ismail Al Amin, you can go ahead.
Peace upon you. My name is Ismail Lamin. Fadl. Thank you, Dr. Ahmed, for presentation. I have some question, 2 or 3 questions. How I know? Is this the beginning of outbreak? And also, is the patient suffering from cholera or Shigella or other water diarrhea? And what is the preparedness and response for outbreak if he sure is an outbreak? And how to protect our community from this outbreak? And also how to treat it with the funerals if we have dead bodies. Thank you.
Thank you, Dr. Ismail. I think Dr. Ahmed Izzeddin is not able to come back. We will wait for him, but Dr. Muntasir or Dr. Sabir, you can proceed to answer if you like the questions. Will that be okay with you, Dr. Muntasir and Dr. Sabir?
Sorry. You hear me?
Yes, we can hear you, Dr. Muntasir. Welcome.
Thank you very much. I really enjoyed today also session. Still we are competing. طيب I will start with the question that been raised by Ismail. And
yes,
if you give me some few minutes, I would like also to acknowledge the preparation for this presentation from Ahmed and Sabir. Really give us a lot of information, particularly those who are deeply involved in the cholera response at any level.
yes,
And our colleague also, they are part of this work. In addition that, also we have to acknowledge those who are working, who are preparing also, and who are responding to the outbreak from the field level up to the high level at all the years that we faced the cholera outbreaks. If we have a look at the outbreaks of cholera in Sudan since late 1990s, we'll find that we have like a cycle, 4 to 5 years of an outbreak, and then another 4 to 5 years of a break, and then came and again cases. And definitely we are not in silo. We are also facing the same that our neighboring countries are facing. So from 1999, all those who remember that, who work as medical officers or even consultants at that time. 1996 up to 1999, we have outbreaks of cholera all through the country, and then from 2006 all through from 2000 up to 2005, no any report of outbreak. Although I found it in some areas like WHO presentations that they included our acute area of Darfur as cholera. And as one of those who were working at that time, the Epidemic Control Directorate, Federal Ministry of Health, no any report of outbreak of cholera because at that time up to 2006. So what I mean that we have not the cholera in Sudan is not endemic, and the way that measure the PAMI and also hotspot areas sometimes mask with the real needs with this vulnerability of population, and even the measurements of availability of safe water in the country was around 50% with the sanitation of low and that, unfortunately. But these even have been exaggerated during this forced displacement and all the during the conflict war. These are also part of our areas that we have to consider for the cholera outbreak in the country. 2006, 2009, then no outbreaks till 2016. Even the report of 2010, it was equal life. And I wish Babikir also is here. And I have seen Saeed is here also. All of us were at that time working in the epidemics control. So then we faced with 2016 up to 2019. And even in 2016 or to 2019, localized areas, in particular 2019, it was mainly in the Blue Nile areas and also Sinnar and part of Jazeera and Khartoum. So again, we have now the BAMI, and the assessment for the BAMI this time didn't include the areas of Darfur and some of the Kordofans because at that time, during the work of the BAMI preparation and also implementation, it was no report of cholera from these areas. But within the time now, we are facing almost all the states that they are reporting cases, and even heavily now the wave is moving toward the west. So for even I think the way that you present Ahmed is very attractive to let us move from a reactive mode to proactive mode, and that requires a multi-sectoral work, multi-sectoral commitment, and also global commitment and contribution. What we are facing exactly that no huge support for the availability of safe water in general in the country. And although they are working, and we have to acknowledge their work, our colleagues in the water, but still they require more funds to launch and to have water plants. In addition, also to maintain the work of the water plants that also we faced during 2006 up to now in some areas that the Ministry of Health are those who are providing the chlorine for the community and even for the water plants. And this is not our mandate, although this is not the recent way, but before it was. in 2006 up to 2009 and also during 2016. But during 2022, we have deep engagement and contribution of our colleagues from water, and they are tackling the way that they to provide this contribution during the response, unfortunately. But during the silent years and also the silent months, we do face a real challenge in sustain availing of safe water. And this is one of the challenges that we are facing for the long run of getting uh, free, the country free from cholera. You said, Ismail, from your points, the first one is if this is cholera or not. Since we know that, and we used to work that to have a confirmed cases during the first reported cases from the new locality and for the cholera new area, and then move to have an EP link. And with the availability of rapid tests nowadays, we are using it as one of the tools for confirmation. So for us, it is cholera because the rapid test and also the culture uh, confirm that this is cholera outbreak circulating from September 2023. September 2023, not before that. And after the war and after the Malaysia did and looted most of the areas and then and also affected the safe water plants in most of the states that they used to be in, like Jazeera and Khartoum. Uh, for the preparedness and response, definitely this is a multi-sectoral. For that reason, we have a water. We cannot say we are in a good shape, but at least we are in a shape that can do the response in efficient way. So this is another area that we have to work on it, to manage it, to have a good response from all, from the community, from the water, from the those who are decision makers, finance, and also from the health at all the levels. We used to have the after action review during the previous outbreaks, and now for the cholera for Khartoum, we are preparing an after action review. And for the general, for the nationwide, we are also preparing this. The after action review for Khartoum, we are preparing it with our colleagues, Save the Children, who supported us in the case management part during the heavy outbreak during this year of Khartoum. And also for the interaction review, this is part of the evidence that Dr. Ahmed talk about to get a systematic review about the pros and cons of what we are doing to improve it for the future. This is from my side, Ismail. I wish that I get some of the answers for you, Sabir and Ahmed, if you are available. And thanks to all who are now available and who are contributing by participating and also actively contributing and having their comments during our sessions. Ahmed, back to you to continue.
Thank you, Dr. Muntasir. Thank you very much for this comprehensive response and for addressing the question by Ismail Alamin. Thank you, Ismail, for your question. And before we take some other questions, I just want to address the points and the questions raised by our commentator, Dr. Sabir. The first one is, as he said, some fragile risk areas might be excluded through the exercise of boundaries identification. Actually, this is a very important, Sabir. This is a very important aspect that should be considered in the process of prioritization, especially in the part of stakeholders validation when we are setting the priority index threshold for each locality. So some localities, as I mentioned, might have a low score, but based on the contextual knowledge and the field-based knowledge, you consider this locality a priority, you as a country and the experts within the country. So you have a room to include this locality, and you are allowed considering the vulnerability factors, and this actually also covered by the Global Task Force methodology. After you did your the indicators, the measurement of the indicators, you go to the vulnerability factors and you assess for the vulnerability factors. And whenever a locality is identified based on the vulnerability factors and the contextual knowledge as a priority, even if the score is low, you can include this locality as additional priority area. You can include even more than one locality, and as long as you are sticking to the population target and to the cases and death target within your BAMIs, the total list of BAMIs, including the additional BAMIs. So this is the first point. The second point, Dr. Sabir, you said what does the Global Task Force provide to help the countries to progress to achieve the roadmap goals? Actually, when you have this endorsed list of priority areas of multi-sector intervention, you will get a good global support. This global support could be in different shapes, like the support from the already existing international partners within your country, in terms of supporting the cholera control, as you already did your the very important exercise of identification of BAMIs, and as I mentioned in the slides, the BAMIs give you a recognition. It's internationally recognized when they are endorsed by the Global Task Force. Everyone has to stick on this list of BAMIs and to plan all their interventions and their efforts based on this BAMIs. At the global level, you get support because the BAMIs list allow you to apply for the preventative vaccine request, and actually it's a very good opportunity for controlling cholera on the long term, because as I mentioned, the preventative vaccine is 2-dose strategy, and the 2-dose strategy is has a protection of 3 years, and these 3 years are good time. You will buy time to improve your other interventions and other pillars, and you can get the preventive OCB for most of the BAMIs identified, also according to specific tools that is available in the by the Global Task Force. So and this support is from Gavi. This preventative OCB is from Gavi, is provided by the Global Vaccine Alliance, Gavi, and part of this support is support to the WASH. They will give you a package of WASH interventions, and they will give you a package also to strengthen the testing capacity of the country. It's like mostly is the rapid test, rapid diagnostic test. You will get support in terms of rapid diagnostic test. You will get a considerable amount to enhance your detection in these areas, in these priority areas. So when you early detect, supported by this testing improvement, you are more likely to early contain and to early response and to prevent the spread to other areas. So this is also part of the global support you get, and we don't forget the support, the technical support you will always have upon request from the global task force itself and from the WHO and so on. This is about the problem on what type of support you get. The last question and the last point is you said, what does the global task no no what's beyond these control strategies that could be ensured for the best control outcome? Of course, we need to have some there'll be efforts beyond these control strategies that are recommended by the Global Task Force and beyond after the identification of boundaries. And actually, if I'm correct, and also you can also, Dr. Muntasir, Dr. Sabir, elaborate on this, or the other experts here with us, Dr. Muhammad Al-Hafiz is here, Manguri is here, and many other senior colleagues and experts here. So from my point of view, what we should do beyond that is actually the very thing is to have the government commitment, commitment and advocacy for these methodological approaches and for these approach that is going to be adopted by the Ministry of Health for cholera control. Another thing which is very important is the partners' commitment in terms of multi-sectoral collaboration. Yes, these are the control strategies, but without commitment from the all partners, from the multiple sectors, and not at the level of the sectors only. I think even at the level of the countries, we need to have inter-country commitment in terms of cholera, strategic cholera control regionally, especially countries that are neighboring each other. And for example, we have some lessons that the cholera, or some experiences that cholera already extended or spread from neighboring countries. For example, like Ethiopia, like South Sudan, and so on. So we need to have inter-country collaboration, especially neighboring countries, in terms of early detection and timely dissemination of information. So we are prepared in the best way to prevent the spread from these countries and to prevent ourselves. The last point in what can be done beyond these strategies is the shift, the cultural shift. I mean, it's very important for all the actors and those who are involved in cholera control to shift in their culture from the response to the preparedness and prevention. We need to shift, and we need to invest on the preparedness. As we know right now, currently, the investment in the preparedness is very limited, and we need to scale this up, and we need to shift our culture from supporting the response only to the preparedness level. And I hope I think I took much time, but I hope I address your point, Sabir. This, from my point of view, we can listen to other colleagues, experts' views in these points. Back to you, Samar. If there are any questions, further questions, we are here to respond, inshallah.
Thank you very much, Ahmed, and thank you, Dr. Muntasir. Uh, for those who are new here, please excuse me for not introducing Dr. Muntasir. Dr. Muntasir is the General Director of Health Emergency and Epidemic Control in Sudan, and he is also the Director of Sudan FETP. Thank you for your comments and your answers. Now we will go to Muhammad. Hey, Muhammad, for his question. He's raising his hand. You can go ahead.
طيب السلام عليكم. Thank you very much, Samar, Dr. Ahmed, and Dr. Saber, for the interesting informative session. I would like also to congratulate Dr. Muntasir and Dr. Najib for the successful third session of this webinar series. It's very, very interesting, and please keep it up. And as this also addressing very interesting and very important topics. Um, uh, I would like just to highlight on uh, the presentation by Dr. Ahmed for the below level of the uh, uh, system thinking model. Number 2, 3, and 4, the pattern, systemic structure, and mental model. And we know all these are, maybe you address it in when you mentioned high level advocacy, but I mean, analyzing and knowing the issues or the root cause analysis is very good approach now, and this will take us back to the question that was raised by Dr. Haytham Bashir in the last session on why are we facing repetitive multiple outbreaks every now and then. And I think we touch base on the root causes, but now uh, we have to think collectively how to tackle this down and how to increase the commitment by the government, by the partners, and how we shift from the reactive funding to preventive, just mentioned also by Dr. Montasir. How can we engage the government by all sectors to have at least a well prepared response, well funded, rather than looking for the treasure box that was demonstrated by Dr. Ahmed, and fight all in one golden coin. I think this is something strategically we have to collectively think and how uh, to mobilize or how to shift the whole government from being reactive to being preventive and proactive. The second question is just considering the dynamically evolving situation in regard to the security, accessibility, how reliable the PAMI is now, and is there a plan to update the PAMI and how frequent? I know the presented, the PAMI is already addressed for the 2025 to 2030, and the situation in Sudan now is very much dynamically evolving and changing. So how can we also include other localities when it's being accessible and the situation is being more uh, visible to us? Thank you very much, colleague. Thank you. Over.
Thank you very much, Dr. Muhammad, for the valuable questions. And I would like please to take a time to thank everyone who are joining us. And we have very special guests with us today. Uh, Dr. Sayed Hamad, he was the former presenter at the former webinar. Thank you for joining us. And also Dr. Salim, and also many of the very distinguished physicians and public health professionals. Thank you all for joining us. Dr. Ahmed, is it okay for you to answer one by one, or do you want to answer at the end of the session?
نرحب بدكتور مبارك الحسني مدير معمل الصحة العامة العلمي موجود مجاب المحاضرة.
Dr. Matasim, your voice is not very clear.
نرحب بدكتور مبارك الحسني مدير معمل الصحة العامة العلمي موجود معنا بداخل المحاضرة.
Welcome, welcome, Dr. I'm sorry, I did not hear the name very clearly. Yes, Dr.
المايك
Muntasir.
اقول استمع واتكلم.
شكرا دكتور مبارك حضورك. نحن سعيدين بحضورك دكتور مبارك كرسني. له باع كبير معانا في الأوبئة. من بداية الألفينات دكتور مبارك كرسني كان نائب مدير معمل الصحة العامة القومي. انضم للسلاح الطبي والجيش، والآن عدينا كمدير لمعمل الصحة العامة القومي. نحن سعداء بك دكتور مبارك اليوم تكون ضمن الحضور، وشكرا جزيلا لحضورك. تفضل يا سمر، كونتينيو.
Thank you, Dr. Muntasir, and welcome, Dr. Mubarak. Uh, I think Ahmed Izzuddin is not here.
Summary.
Ahmed Izzuddin, do you hear me? Yes,
Yes,
okay.
I hear you. We
So,
can take 2 to 3 questions and then we can answer them together.
okay.
I think one by
Okay,
one
so
will take much time and we are already running out of time.
yes, okay, I agree. Now we will take Ahmed Al-Amin. Ahmed Al-Amin, you can proceed to ask your question.
شكرا. السلام عليكم.
Alaikum assalam, we hear you very well.
Okay. First of all, thank you, Dr. Ahmed, for the presentation, and thank you for Dr. Sabir. And before that, I extend my thanks to who prepare these sessions and invite us and allow us to participate and to contribute. My question is, it is not a question, it is a comment. If we want to work proactively to tackle cholera, we have to work mainly with our internal partners, mainly the government, because the prevention is not a mandate. Is a very pure mandate of the Ministry of Health. The prevention of cholera is a mandate of other governmental partners outside the Ministry of Health. And unfortunately, their contribution is not as expected to be. If they are not included, if they are not participating deeply in the prevention of the cholera, unfortunately, the Ministry of Health will be fragile to cover all aspects of the cholera issue. So it is not an easy way to bring them to the port to work with us closely and honestly, because the decision is beyond the Ministry of Health. It is a developmental questions, and I could say that it is a political questions. So if Ministry of Health take all the package of the intervention to address cholera issue in Sudan, this will not be effective enough to solve the problem. Who provides safe water is not Minister of Health. This is the first point. We cannot rely on the international donors to support us, because international donors, they come to you when the crisis already happened. And they have very limited funds and resources for the preparedness stage. But the main objective of them is to save life after the crisis happened. And very strange things, the highly affected locality is not in the area of insecurity or humanitarian crisis. The localities that affected by the cholera are approximately in area with security instability. If you go back to the map of the cholera outbreak before the war, the picture during the war, of course, not well known, because I think not all part of Sudan, especially in Darfur, are reporting the cases due time, and the problem there is not clear. The health system is not is very fragile. It is not working now. So, in summary, you have to work inside the Sudan to address the cholera issue. We have to advocate among the decision makers, and this will take long time, but I think there is no another way. There is no alternative. And we have advocate among the public. And to advocate among the public, you have to provide information. And this is here the role of the health promotion department. It will work to raise the awareness of the public that the problem of the cholera in Sudan cannot be solved by Ministry of Health. There is a very important partner. They come on the board and take their lead and take their and do their part. This is my second point. That is all. That is all. Thank you. Thank you.
Thank you, Ahmed Alamin. Now, Muhammad Awadallah, you can go ahead and ask your question.
Okay, thank you very much, Dr. Ahmed, for actually this insightful session. And really, I am amazed by the knowledge you shared and also about this critical issues. And actually, regarding to proactive approach you mentioned here, I have a question about what are the key new tools or new tools in global cholera risk mapping. Like as Dr. Muntasir said in a previous session, they use modeling and also regression, and also how to based on your knowledge, how do they can improve prediction accuracy compared to others models, and also how we can use it to get benefit in order to improve our proactive approach towards preventing of the cholera. And that is all.
Thank you, Muhammad Awad. Um, uh, Dr. Yusuf Shawish, you can ask your question.
Thank you for this post. I'm very happy to join this webinar. And I'm very glad to meet my colleague and my boss from All Sudan. I'm Yusuf from West Darfur. Mainly now I'm from Habila. I talk to you. Maybe Dr. Ahmed, he knows that. All Ahmed. Ahmed Al-Amin and Ahmed presenters. And Manguri and Muntasir and Dr. Al-Fatih. Thank you, Dr. Najib. Thank you, Dr. Sabir. My concern regarding this outbreak of cholera in West Darfur and neighbor state in Central Darfur. They reported some cases, and depending on rapid test, most of these samples tested by rapid test are positive. And the characteristics of this outbreak, if you said this is an outbreak, it's not like a cholera outbreak, not similar like that, because all those cases coming from different sites, and only one cases were reported, then no cases further reported to central site or to our system here in West Darfur. For example, inside Jinena, from Ardamata, who is some people they know that this area. One case from Ardamata, one case from Al-Kifah area, one case from Tandalti. These like sporadic cases, and when it is received, will be confirmed as a cholera. My question for my boss Al-Karsani, how far we can depend on rapid test to be as a reference for to confirm the cholera. And also I'm not satisfied for the processor to confirm these cases, because this is not on hand of government. It is bring it by some organization, and every case is coming to site is just confirming. Up to date, only 4 localities reported cases, maybe reach about 39 cases as confirmed cases for cholera. If in the previous, we depend on reference lab, Khartoum, but now the situation is worse and worse. And maybe can we say this outbreak as deliberated an outbreak or what? Because up to date, since August, only 39 cases reported, and take it as positive cases, and no other cases were reported. Only 1 case, and even the people who contact these cases not affected, and all the chance of to be affected the area are there. No control for water, no control for insecticide, and so on. Nothing was done for prevention, but unfortunately, the outbreak declared. Now, last case is reported to isolation area in Habila before 2 days ago, and no other cases reported. Now, can we say this is an outbreak, real outbreak, or deliberated outbreak? That is all. Thank you for all. Please pass my grade to all my colleagues here. Thank you for to meet you again, and hope to meet you. Thank you. Over to you.
Thank you. Now Dr. Mu'tasim al-Manguri. And I think this will be the last question. And we will go very fast on the chat box after that. Then we will go to the answers. Dr. Mu'tasim, ask your question, please.
Thank you for invitation and nice presentation. For me, I want to add something for laboratory information. Since the outbreak, we have strategic testing for cholera.
صوتك بعيد يا منقوري.
مثلا يا منقوري. السلام عليكم، كده واضح؟ تمام.
أيوة واضح.
السلام عليكم، كده واضح. من بداية الوباء كان عندنا استراتيجية حقت فحص شراكة مع إدارة الوباء، إدارة الطوارئ، مكافحة الوباء الاتحادية. بيكون عندنا تيستينج استراتيجي initial confirmation phase في new locality. We use rapid test and culture gold standard identify verification by cholera. والخطوه الثانيه سستين ريسبونس فيس دي بعد اللي حصل لنا الكونفرميشن. اللوكاليتي حتشتغل بالريبت تيست فقط، وعندهم اعداد محدده للفحوصات حقت الريبت تيست. عندنا على مستوى الناشونال بابليك هيلث لابوراتوري بنشتغل الريبت تيست، وبنشتغل الكلشر، وبنشتغل الانتي مايكروبيال تيست، وبنشتغل برضه البي سي ار، وبنشتغل عندنا جينوميك سيكونسنج. عندنا يونت ممتازه جدا مراقبه لنا تاسست قبل الحرب دي باسبوعين، وبدعم منظمه الصحه العالميه في اغسطس 2023 تم تاسيس معمل الصحه العامه القومي في البحر الاحمر، وكان زراعه ساندة لكل ادارات وزاره الصحه الاتحاديه من الطوارئ والتحصين في تشخيص الكوليرا، لانه التاكيد المعملي هو كان التدخل حق اللقاح. ناس محمد عز الدين بيشتغلوا شغل جميل جدا. الان عندنا معمل كسله ومعمل الخرطوم، الاسبوع ده ان شاء الله حيشتغل لنا الكوليرا جاهز، لكن التاكيد عشان اللقاح يخش البلد بيكون من البحر الاحمر. القضاري برضه الاسبوع اللي فات اشتغلوا عملوا كلشر في معاملهم وماشيين ممتاز جدا. شكرا جزيلا.
Thank you, Dr. Muqtasim Al-Manguri. Uh, Now there is the last question from Dr. Najib. He is asking you, Ahmed, does it count to periodically update your PAMIs to account for the dynamic current changes? Now please answer. Ahmed Izzeldin,
Yes,
floor is
yes,
yours.
thank you. Thank you very much, Samar, and all those who raised these very important points. Um, I'm going to respond according to my limits. Actually, it's very. I don't know how can I talk with the presence of all these experts in the sessions, but I'm going to add some of the answers, and you can elaborate more in any of the points that is raised by the colleagues. So thank you, Dr. Muhammad Al Hafiz, for your feedback and comments. And I think you highlighted one point about the other localities that can be included after the situation gets better and the access improve and so on. So for the list of BAMIs, actually the period of analysis extended up to December 2024, and at that time there was cholera even reported from that inaccessible areas, and they are included in the analysis, and they are already part of the BAMIs. Localities from Kordofan, localities from Darfur, and so on. However, this is because the period, the analysis period is taking is taken from 2016 to 2024. This is why some localities that are even in the areas that is now classified as inaccessible are already included in the analysis and already now part of the subset of families that are priority now. But in terms of the implementation and the inclusion in the national cholera plan, which extend up to 2030, actually a special consideration should be made for these localities that are now inaccessible. Whenever they get accessible, they should be part, and they should be considered in within the plan, and the interventions and implementation of activities should be done in these localities. It's very important, and this actually takes me to the question raised by Dr. Nagib, which is how periodically we can update this list of boundaries. According to the Global Task Force, because upon this list, we depends our national cholera plan, which extends for 5 years. We rely. This plan is dependent on this prioritization exercise. So the standard is to update every 5 years. Every 5 years, the list should be updated, as our plan is for 5 years, and this is a sufficient time for you even to evaluate the impact of your interventions, of the measures that are implemented throughout the period of the plan in these priority areas. What is the impact? And then you can update according to the updated epidemiological situations. But the Global Task Force also recommends, whenever there is a significant epidemiological shift in cholera, here you are allowed to update the prioritization, or to conduct your prioritization exercise, and to update your list of BAMI, and accordingly update your national cholera plan. But the standard is every 5 years. So this is a point by Dr. Nagib. Another comment from Dr. Ahmed Amin. Thank you for your comment, and for highlighting the very important aspect of of the preparedness part. And your point on that the preparedness is not in the agenda of the most of the organizations and the stakeholders, and the cholera is relying on some stakeholders that are not are outside the yard of health, like the Ministry of Water Resources and so on. And they need to be committed, and they need to strongly adopt this prioritization priority list, and they need to also to strengthen their efforts in terms of preparedness, rather than only get engaged only when some outbreaks are occur or some outbreaks occur. They at this point they get involved, and they are engaged by the leading committees, or the higher committee, for example. We need to shift. I don't know, maybe other commenters, Dr. Muntasir, Dr. Muhammad Al-Hafiz, Dr. Najib, you can elaborate more on this point, how we can have them engage even at the preparedness level, with commitment and with advocacy from the highest levels to the lower levels, and how we can address the problem of insufficient resources and the very limited resources, domestic resources, that is allocated by the Ministry of Finance for the health, and it's not allowing investing for the different ministries. I mean, not allowing for investing in the long-term preparedness strategy, or long-term infrastructure improvement regarding the wash and water aspects. So I didn't hear, actually, Dr. Muhammad Awdullah, I didn't hear your question very well, but some of the words, I think the new tools in risk mapping, maybe you are talking about the prediction or the forecasting, how we can align this, how we can integrate this into the tool of the Global Task Force for prioritization or for risk analysis. I think this is a very important point. The tool is mainly depending on the historical data and the historical epidemiological indicators. And if there are any other efforts regarding the forecasting or any prediction, what is the possible epidemiological picture in the future, I think this should be aligned and should be part of the prioritization exercise, and we can put that in the area of assessing the vulnerabilities. Any localities that are outcome of the prediction or forecasting that showed high risk of cholera in the future, I think it should be, if it is not already part of the priority areas through the tool, we can put it as if this depends on the accuracy of the tool we are using in terms of forecasting. If there is a good level of accuracy of this tool, and this locality is a result of our forecasting exercise, and it shows that it will have very high risk in the future, we can include it as an additional BAMI if it is not included in the priority list, as additional BAMI, and we justify this through our through the forecasting process we did, and this is considered a vulnerability. So this is a locality that will have increased vulnerability in the future, and should be part of the priority areas. But to me, I think the forecasting results could be to a good extent, or to a considerable extent, similar to to the tool, because it also depends on the historical data and the historical epidemiological data. So it is most probably bringing the same localities to a greater extent as priority localities, with some other additional one that we can include as additional localities. So we move now to the question by Dr. Yusuf Shawish. I'm very happy that you are part of this session, Dr. Yusuf. Dr. Yusuf is my first HIG director when I was in the Ministry of Health West Darfur in the Health Emergency and Epidemic Control Directorate in 2020 during COVID-19. Very happy to have you with us today, and I'm very happy to know that you are still one of the soldiers of the health emergencies and epidemic control, and you still have some efforts, or maybe huge efforts in your area. And I hope all this crisis settle up very soon, and we can re-meet together, and we can reconnect again and the field work, inshallah. So your question is about the cholera in your area and the reliability of the RDT. I think, Dr. Manguri, you need to elaborate more on the point of Yusuf on the reliability of the RDT kits that is used by the organizations here, because I think this is a very important point. We think that each case that was tested by this RDT proved to be positive cholera case through the RDT. So he is asking about the reliability of this test. It always gives positive results, and whether you have this test, is it a credible test? Is it already pre-qualified by the national lab? Do you know about it? And so and things like that. And for the cases that you is not following the button, the common button.
Ahmed, Dr. Ahmed, I'm
Yes, I
sorry,
already
very
finished.
sorry for interruption, but please,
I already
you
finished.
only have, okay,
I already
1
finished.
minute.
Yeah, sorry. Yes.
Okay.
So for the button of cholera that you think is uncommon, is not the expected button of cholera. Maybe these cases, maybe to me, and Dr. Muntasir might or Dr. Father might elaborate more. To me, they might be imported cases from other localities, from other Darfur states, because now we have cholera and all the 5 Darfur states, in Central Darfur, North Darfur, South Darfur, and East Darfur, of course. They might be imported. They might have some links with other cases in other localities. This is why they are sporadic, and one case here, one case there, and alhamdulillah, it's not spreading massively in these localities. So thank you very much, you all, for your very important points. I hope I addressed most of them, and I leave the stage for the supervisor and advisor to elaborate more on this point. Thank you very much.
Thank you very much, Dr. Ahmed Azzuddin, for your very insightful answers and interactions. We thank you very much. We are very late at the time, but let's welcome Dr. Al-Fadil. You have a minute. Thank you.
Okay, thank you so much, Samar. Thank you so much, Dr. Ahmed, Dr. Sabir, for your preparing this presentation and good and very comprehensive presentation. Really, I'm very glad. I would like to add regarding the issue of the BAMIS, as Dr. Ahmed said, currently we selected 52 localities, like the more vulnerable localities, during these 5 years, and also that is going aligned with the proactive OCV. That is a very important one, because already we reduce and use a very low indicators, our score, in order to not make huge localities, and then we can submit it to ICG and refuse to give us the OCV. That's why we using the very low score, and they give it already 52 localities. But that does not mean that we are neglecting the others, because as you know that currently we all the state, I think the state in Sudan, they are already affected by the cholera, and even also more than 100 localities That means all the localities is vulnerable. And currently we're working on the cholera strategic planning for the BAMIS localities, 52 localities. But inshallah, after this, finish this strategic planning, we have also to do a very comprehensive strategic planning for the cholera, and that is to focus on the issue of the preparedness, as our colleagues mentioned, Dr. Ahmad, Lamine, that is the preparedness issue. It is very important. And even also the issue of the control and prevention of the cholera. It's not only Minister of Health, we have others like our colleague in WASH sector. And also I would like to say to Dr. Ahmed Lamine, the WASH sector, it is with us. Even before yesterday, we have a meeting with them. And even also this strategic plan is a part of this, the pillar of the WASH already done by our colleague in the WASH sector, our National Water Corporation. That is also, I would like to recognize that we also, inshallah, we develop the college direct planning for the other Sudan in the coming months, inshallah. Another things, as our colleague Yusuf really, it is my colleague and the classmate at the university, and also currently in Guinea. That means we are ensure that the situation will be very healthy, because already the people like Yusuf till now there. And just I capture one point from him regards the issue of the scatter case, like the outbreak. We can announce that this is the outbreak. Just I would like to say, because the outbreak already declared in last 24 July for all Sudan, and from that time up to now already the outbreak continues. And even also that the vaccine already done in Guinea based on that declaration. And also the people, when there is some cases, we started directly with Dr. Ahmed, another colleague, for the proposal for the OCV for the vaccine. And already there is 2 localities currently in West Darfur already they received the vaccine. And inshallah, I hope that the cases will be decreased, inshallah. Thank you so much, and over to you, Dr. Samar. Thank you so much.
Thank you very much, Dr. Al-Fadil. And as we come to the end of this webinar, I would like to thank you all, the participants. I would like to thank the organizing team, especially Muhammad Awadallah, Hiba, Mus'ab, and Dr. Najib for the endless support, and Dr. Muntasir. And please stay tuned to all our webinars. The next Saturday will be a webinar about rodent-borne disease by Dr. Nada Abdel Jalil. She is assistant professor at the National Public Health Laboratory and One Health focal point. Now we will move to you, Dr. Muntasir, please, to close this webinar. And thank you all.
Thank you very much, Samar. And I would like also to thank Samar. Dr. Hanadi is raising her hand. Dr. Hanadi, you can have 1 minute. Please.
Hello, everybody. You can hear me well?
Yes, we can hear you very well.
Okay, thank you for the presentation. Very excellent presentation, Dr. Ahmed, Dr. Sabir, and for all the comments received. I'm sorry for joining late because I have a technical problem. I joined from not this link. I have just one comment. I am very happy that Dr. Ahmed Izzeddin, in his last slide, he mentioned One Health on cholera context. And that's very great because we are talking about multi-sectoral approach to tackle cholera, but now One Health is very needed to control and to prepare for cholera. The other thing is that about the laboratory capacity for diagnosis of cholera in the veterinary side, because lastly incidents were registered for some problems of like animal products banning from some countries, Gulf countries and other countries, for some products from countries that is cholera that have cholera outbreaks or endemic for cholera, for banning like fish, like meat products. And this needs very close collaboration between the veterinary laboratories and the public health laboratories in terms of establishment of investigation capacities for cholera, because it was not addressed in the laboratories of animal health, like in the Central Veterinary Research Laboratories. And this need to be activating our mechanisms of collaboration, like the MOU between the STAC, National Public Health Laboratory, and Central Veterinary Research Laboratory regarding the microbiology testing, or even the rapid test of cholera within veterinary laboratories. This is my point. Thank you for the last chance, Dr. Montasir, and over to you.
Thank you, Dr. Hanadi. Exactly, to be open, it was banning for Sudan exportation of meats from one of the Gulf countries, and this is the first time we have this issue. And now, although we did address and put it as a cholera outbreak or for national concern, but still it affects us economically. Maybe for the future we have to consider that to work more with our colleagues in animal. I would like to thank very much Samar for the smooth moderation, and also Ahmed and Sabir for this comprehensive presentation and enriched knowledge for the cholera risk and strategic thinking for the future. And it was great that also we have our colleagues, Dr. Ahmed Al-Amin, who was head of surveillance in Epidemics Control Directorate for Riyadh, and also Yusuf, who graduated from FETP. Now he's working still in this tough area and tough time. Wish you all the best, Yusuf, and all colleagues who are working now, and those who are fighting against the outbreaks and in these hard to reach areas. I would like also to thank the organizers, and thank you all for attending and your patience, although we moved out for almost 2.5 or 2 hours and 35 minutes. We are beyond the time. Wish you all the best, and wish you also to enjoy and also participate in on the coming webinars from our colleagues. I appreciate the work, and also please, those who are interested to present, please contact Hiba, Samar, Muhammad Awad for their contribution, and they will arrange for you their presentation. Thanks to all of you, Sayyid, Salim, Muhammad Al-Hafiz, and thanks also to Dr. Mubarak Karsani for joining us this time. I wish you all the best in your new and old area, and we will get more benefit as HIC from your presence. Thanks a lot all, and wish you all the best. See you inshallah coming week.
Thank you. Goodbye.
شكرا جزيلا. السلام عليكم.
Thank you so much.
شكرا جزيلا. جزاكم الله خير.
Thank you.
شكرا. السلام عليكم ورحمة الله وبركاته. نلتقي. شكرا جزيلا.
الأسبوع الجاي إن شاء الله.